This is a trauma patient, and right now you need to know one thing. Is there internal bleeding? So you grab your ultrasound probe and check 4 spots: the right upper quadrant, the left upper quadrant, pelvis, pericardium. But why those specific points? You are checking the dependent spaces, the places where free fluid will collect first based on gravity and anatomy. The entire FAST exam is built on an understanding of abdominal spaces. And today, we are going to build the complete map. One video, every abdominal space you need to know for surgery, radiology, and clinical exams. We will start by orientating ourselves in the torso, what we actually mean by the abdominopelvic cavity, how the peritoneum lines it, and why it creates what we call potential spaces. Then we will move into the peritoneal cavity itself, breaking down its compartments. From there, we will go into the pelvis and see how the pouch of Douglas and the rectovesical pouch are formed. Then we will look behind the peritoneum into the retroperitoneal space, how it's organized into 3 compartments and why pathology behaves differently here. And finally, we will tie everything together clinically, how to predict where pathology spreads and why the FAST exam looks exactly where it does. What's up everyone, my name is Time, I'm a medical doctor and I make animated medical lectures to make different topics in medicine visually easier to understand. If you would like a PDF version or quiz of this presentation, you can find it on my website, along with organized video lectures to help with your studies. Alright, let's get started. Our chunk is divided into 2 major cavities. The upper part is called the thoracic cavity, and it contains the 2 pleural cavities laterally and the mediastinum in the middle, which we covered in the previous video. The space below is called the abdominopelvic cavity, which is the region we are focusing on in this video. Now, the abdominopelvic cavity is not one empty box. It is organized by a single membrane called the peritoneum. Now, let's back up for a moment. Here we see the anterior view of the entire trunk with all its muscles, right? If we gently just peel off the muscles and connective tissue on the left side, we will eventually get to a membrane that covers all the internal organs. This is called the parietal peritoneum. And now, if we just slice the body in half and look in this direction, we will be able to see inside the parietal peritoneum and see all the internal organs here. Just for orientation, we can see the liver, the end part of the stomach, since we cut the whole body out. We can see the transverse colon, bunch of small intestine, rectum, bladder. Back here, we got the duodenum. We can also see the pancreas, the right kidney, and of course the diaphragm here, separating the thoracic from abdominal cavity, which contain things like the lungs, the esophagus, trachea, heart, and so on. Now, the parietal peritoneum we saw earlier covers all of these abdominal organs and forms kind of a pocket. This is just an approximate highlight, but notice one thing. There is a special membrane that goes out from the back side of the body and then wraps around all of these organs. And this special membrane is called the visceral peritoneum. And depending on your relationship to this membrane, you are either inside the peritoneal cavity or behind it in the retroperitoneal space. This is the fundamental division: peritoneal inside, retroperitoneal behind. Now, the space inside the peritoneum, the peritoneal cavity, is sometimes called the greater sac. This is the main cavity we are going to explore. There is also a smaller hidden pocket behind the stomach called the lesser sac, which we'll come to later. But the peritoneum does more than just line walls and cover organs. What it does is, it reaches out from the back of the abdominal wall, wraps around the organs, around the small intestine too. It just don't look like it here on this diagram. But it wraps around the organs, and as it does that, it creates folds. And these folds have names depending on what they do. When a fold of peritoneum attaches an organ to the posterior abdominal wall and carries its blood supply, we call it a mesentery. The small bowel, for example, is suspended by the mesentery of the small intestine. The transverse colon is suspended by the transverse mesocolon. When a fold of peritoneum connects the stomach to another organ, we call it an omentum. The greater omentum is a large fold that hangs down from the greater curvature of the stomach, draping over the intestines. The lesser omentum is a smaller fold that connects the lesser curvature of the stomach to the liver. And when a fold of peritoneum connects an organ to the abdominal wall or to another organ, but it's not the mesentery or omentum, we simply call it a peritoneal ligament. The falciform ligament, for example, connects the liver to the anterior abdominal wall. This is generally how the peritoneum is organized. Now, seeing all of this first will make the next part of this video much easier to understand, because these folds divide the peritoneal cavity into compartments. They act like walls separating one area from another, and between these walls, they create spaces. Now, the spaces we are about to cover are potential spaces. That means, normally, there is no visible gap. The peritoneum is pressed against itself, so you will not see these spaces on normal CT scan. But add some fluid, whether it's blood, pus, ascites, and suddenly these spaces open up. They become visible. They become clinically relevant. This right here is the right subphrenic space, which is in this region. And this is why understanding these spaces matter. When pathology happens, fluid does not spread randomly. It follows a specific map that the peritoneum creates. So let us now look at how the peritoneal cavity is divided into compartments. Remember the transverse mesocolon, the fold that holds the transverse colon? This structure acts like a horizontal shelf, and it divides the peritoneal cavity into two compartments. Everything above the shelf is called the Supramesocolic Compartment. Everything below is called the Inframesocolic Compartment. Above the transverse mesocolon, you have the liver, stomach, and spleen, along with all the spaces around them. Below, you have the small bowel, the mesentery, and the associated spaces we will talk about. Now, why does this division matter? Because when a small amount of fluid collects, it tends to stay within one compartment. The transverse mesocolon acts as a barrier. But if there is enough volume, fluid will find ways to move between them. We will see exactly how that happens later in this video, but one more thing I need to mention regarding the supramesocolic compartments. Okay, this is going to look very weird visually, so I'm sorry in advance. Remember I showed you that this was the parietal peritoneum? The parietal peritoneum is basically going to fold and anchor the liver to the anterior abdominal wall and diaphragm. This fold is called falciform ligament, and what it does is, if we cut a part of the peritoneum, we can see that it creates a barrier between the right subphrenic space and the left subphrenic space. Here's a better weird angle, as you see here. So naturally, fluid on the right side does not easily cross to the left, and vice versa. So when we talk about subphrenic collections, we always have to specify right or left. Let us start with the right side. The right subphrenic space sits between the dome of the diaphragm above and the superior surface of the right lobe of the liver below. Medially, it is limited by the falciform ligament. Posteriorly, it is limited by the right coronary ligament. Just a side note, this is called the bare area of the liver. This is where the liver faces the diaphragm directly, with no peritoneum covering it. So the right subphrenic space cannot extend into this area since it's extraperitoneal. Now, this space is not isolated. It communicates freely with the right subhepatic space below the liver, and inferiorly, it communicates with the right paracolic gutter running down the flank. Why does this matter clinically? Because infections from the lower abdomen, for example a ruptured appendix or blood, can track up the right paracolic gutter and end up in the subhepatic or subphrenic spaces. This can, for example, form right subphrenic abscess. Make sense? Now, let us move to the left side. The left subhepatic space sits between the diaphragm above and the left lobe of the liver, the gastric fundus, and the spleen below. Medially, it is separated from the right side by the falciform ligaments, and it spreads far enough to the left to surround the spleen, so it forms the perisplenic region. But here is the major difference compared to the right side, the phrenico-colic ligament. This is a fold of peritoneum that runs from the splenic flexure of the colon up to the diaphragm, and it partially blocks communication between the left paracolic gutter and the left subphrenic space. So while fluid on the right side can travel freely from the pelvis up the right paracolic gutter all the way to the right subphrenic space, on the left, this pathway is partially obstructed. This is why right-sided subphrenic abscesses are more common than left-sided ones. The anatomy on the left side is literally providing some protection. Now, let us go below the liver to the right subhepatic space. This space has two parts, an anterior portion and a posterior portion. The posterior portion has a special name. We call it Morison's pouch, also known as the hepatorenal recess. Morison's pouch sits between the posterior surface of the right lobe of the liver above and the upper pole of the right kidney below. Inferior-medially, it is bordered by the hepatic flexure of the colon and the second part of the duodenum. In this view, I just cut the liver horizontally across the right lobe so we can expose this pouch better, but keep in mind that usually the liver covers this area. Now, here is why this space is so important. When a patient is lying supine, Morison's pouch is the most dependent part of this entire supramesocolic compartment. Gravity pulls fluid here first. So when you perform a fast exam on a trauma patient, this is where you look. And what you would normally see is a liver and the right kidney without any fluid between them. But if there is free fluid will appear as dark and echoic stripe between the liver and the kidney. That is blood in Morison's pouch. This space communicates superiorly with the right subphrenic space and inferiorly with the right paracolic gutter, so fluid can arrive here from above or from below. Alright, let's go back. We did the right subhepatic space, but on the left side, there is the left subhepatic space. This sits below the left lobe of the liver, in front of the stomach. But behind the stomach, there is a completely separate compartment called the lesser sac, also known as the Omental Bursa. Earlier, I mentioned that the peritoneal cavity is divided into a greater sac, which is basically the whole compartment, but it also has a lesser sac, which is a smaller pocket that sits behind the stomach, separated from the greater sac. Now, between the stomach and the liver, there is a fold of peritoneum called the lesser omentum. Think of it as a curtain. As you see here, the lesser sac sits behind this curtain, and the only door connecting this hidden room to the rest of the peritoneal cavity is a narrow passage called the epiploic foramen. Let's just expose this foramen a little bit more. This foramen sits between the hepatoduodenal ligament anteriorly, which is the right edge of the lesser omentum, and the inferior vena cava posteriorly, as it continues down. The portal triad runs within the hepatoduodenal ligament, containing the portal vein, the hepatic artery, and the bile duct. Now, why does the lesser sac matter clinically? Because the pancreas forms its posterior wall. In acute pancreatitis, inflammatory fluid leaks directly into the space, forming what we call lesser sac collections. If we take a look at this CT here, the pancreas is back here, and the stomach is in front of it. Between them, normally you can't see the lesser sac, but in this CT you will see fluid sitting in this region, and with clinical history you can normally tell is this due to perforated ulcer or anything else. Alright, that was the supramesocolic compartment. Now let us move below the transverse mesocolon into the inframesocolic compartments. Let's just go through something again really quick. Here we see the anterior view of the abdomen. Between the liver and the stomach, there is the hepatogastric ligament, which is part of the lesser omentum. It connects the liver to the lesser curvature of the stomach. Now, hanging down from the greater curvature of the stomach is a much larger fold called the greater omentum. This drapes over the intestines like an apron and then loops back up to attach to the transverse colon. If we look at the whole thing from the side, you can see another important structure, the small bowel mesentery. This is a fold of peritoneum that suspends the jejunum and ileum from the posterior abdominal wall. Imagine for a second now, we are looking at the anterior abdominal wall. We've removed the small intestine and exposed the mesentery. The root of the mesentery attaches diagonally from the duodenojejunal flexure on the upper left down to the ileocecal junction on the lower right. This diagonal attachment divides the inframesocolic compartment into two spaces, a right inframesocolic space and a left inframesocolic space. Now, the thing is, the right inframesocolic space is smaller. It is partially boxed in because the mesentery attaches to the cecum, so fluid here does not easily drain into the pelvis. The left inframesocolic space is larger and it opens directly into the pelvis, so fluid on the left side has a free pathway down to the pelvic spaces. Then there is the right and left paracolic gutters. These are on either side of the abdomen, between the colon and the lateral abdominal wall. Think of these as highways connecting the pelvis to the upper abdomen. The right paracolic gutter is the major route. It is larger, deeper, and has no significant barriers. Fluid, whether blood, pus, or ascites, can travel freely from the pelvis up the right gutter into Morison's pouch and also all the way to the right subphrenic space. The left paracolic gutter exists too, but remember the phrenico-colic ligament somewhere in here? It partially blocks the superior end of the left gutter, making it less efficient pathway for fluid to travel upwards. Now, one more thing I want to highlight here before we move on. Peritoneal fluid is constantly moving, it is not static. The subdiaphragmatic space has negative pressure, especially during inspiration. This creates an upward suction that pulls fluid from the lower abdomen towards the diaphragm, mainly through the paracolic gutters. At the same time, gravity pulls fluid to dependent areas. In a supine patient, that means Morison's pouch and the pelvis. In an upright patient, the pelvis becomes the primary collection site. This is why, on fast exam, you check multiple locations. right upper quadrant, left upper quadrant, and pelvis. You are checking all the dependent spaces based on patient's position and fluid dynamics. Okay, so far we have talked through what the abdominopelvic cavity is. We've covered the peritoneal cavity, how it's divided, its major spaces, and how fluid moves through it. As the peritoneum continues inferiorly, it goes into the pelvis and covers over the pelvic organs. And as it does this, it creates pouches. The anatomy here is different in males and females, so let us look at each. In females, the peritoneum covers the bladder, then the uterus, and then the rectum. This creates two pouches. Between the bladder and the uterus is the vesicouterine pouch. Between the uterus and the rectum is the rectouterine pouch, also known as the pouch of Douglas. The pouch of Douglas is the most dependent part of the entire peritoneal cavity in females. Whether the patient is supine or upright, fluid will collect here first. This is why on ultrasound or CT, this is where you look for free fluid in the female pelvis. It is also why a ruptured ectopic pregnancy presents with blood pooling in the pouch of Douglas. In males, there is no uterus, so the peritoneum covers the bladder and then the rectum directly. This creates a single pouch called the rectovesical pouch. This is the most dependent peritoneal space in males. Both of these are the lowest points of the peritoneal cavity, and both are very important locations to check for free fluid. Now, we have covered everything inside the peritoneum. Let's now go behind it into the retroperitoneal space. The retroperitoneal space is the area between the posterior parietal peritoneum in front and the posterior abdominal wall behind. It sits on either side of the vertebral column and contains structures that are not covered by the peritoneum, or at least not fully. Let's just remove the posterior abdominal wall and expose it fully. So now we are looking at the abdominal cavity from behind, after removing the bones and muscles, right? Some organs are primarily retroperitoneal. They develop here and stay here. These are organs like the kidneys, the adrenal glands, the ureters, the aorta, and the inferior vena cava. Other organs are secondarily retroperitoneal. They originally had the mesentery during development, but later fused to the posterior abdominal wall, like the duodenum, the pancreas, and the ascending and descending colon. Because these organs are only partially covered by the peritoneum, some literature also refer to them as mesoperitoneal. Now, the retroperitoneal space is not one open area. It is divided by layers of fascia into 3 compartments. And to see those compartments better, let's take this guy and just slice him in half and look from this direction. It's a little bit narrow in this region, so I've faded the liver to be able to see them better. But the first is the anterior pararenal space. This sits between the peritoneum in front and the anterior renal fascia behind. It contains the secondarily retroperitoneal organs, the pancreas, the duodenum, and the ascending and descending colon. Why does this matter? Because in, for example, acute pancreatitis, inflammatory fluid can spread in 2 directions. Anteriorly, it can leak into the lesser sac, as we saw earlier, but it can also spread posteriorly and laterally within the anterior pararenal space, spreading along the colon, crossing the midline, and extending toward the pelvis. The anterior pararenal space has no barrier in the middle, so there's free communication between the right and left sides. The second compartment is a perirenal space, also called Gerota space. This sits between the anterior renal fascia in front and the posterior renal fascia behind. It contains the kidneys, the adrenal glands, the proximal ureters, and the renal vessels, all surrounded by perinephric fat. Clinically, this is where you see perinephric abscesses, hematomas around the kidneys, or urinomas after trauma. The third compartment is the posterior pararenal space. This sits between the posterior renal fascia in front and the transversalis fascia behind. It contains only fat, no organs. This space communicates with the fat of the flank and extends down towards the pelvis. In trauma, blood from a ruptured abdominal aortic aneurysm can spread into this space, appearing as a hematoma in the posterior pararenal fat. Okay, we have now gone through the major anatomy of the abdominal spaces. Let us see how it applies in real clinical scenarios. Let's go back to the FAST exam. FAST stands for Focused Assessment with Sonography in Trauma. It is a rapid bedside ultrasound used to detect free fluid in trauma patients, which in an acute trauma setting is assumed to be blood. The exam evaluates 4 predefined locations. The first one is the right upper quadrant. In the right upper quadrant, we are examining the space between the liver and the right kidney, the hepatorenal recess, also known as the Morison's pouch. On a normal ultrasound, you can see that there is no visible space between the liver and the kidney. They appear right next to each other. That is because Morison's pouch is a potential space. Normally, it does not exist as an open gap. But in trauma, when there is bleeding in the peritoneal cavity, fluid collects here. And on ultrasound, fluid appears dark. We call it anechoic. So instead of the liver and the kidney sitting directly next to each other, you see a dark stripe between them. That dark stripe is blood in Morison's pouch. In an unstable patient, free fluid seen here on FAST usually represents significant intra-abdominal bleeding. That finding alone is enough to justify immediate operative management. In the left upper quadrant, we are looking at the space around the spleen, called perisplenic region. On this normal ultrasound, you can see the diaphragm, this bright white curved line. Right next to it is the spleen, and below that, the left kidney. And you can see clearly there is no visible space between them. They are sitting directly against each other. But in trauma, when there is bleeding, most commonly from splenic injury, fluid collects in this region. It appears between the spleen and the diaphragm and can flow around the inferior and lateral surfaces of the spleen. Again, on ultrasound, this fluid appears as dark anechoic stripe. This view is technically more difficult than the right side and can be slightly less sensitive, but when free fluid is identified here, it is still highly specific for intra-abdominal bleeding. In the pelvis, we are checking for fluid in the most dependent spaces. In males, here is a normal pelvic ultrasound. Ideally, we want the bladder to be full to get a better view, but in a trauma situations, that is not always possible when we're doing a FAST exam. Here we can see the bladder, so this is a short axis view, the probe is in a transverse position, and down here is the prostate. What we are interested in is to see if there is fluid around the bladder, which in this case there is no fluid around the bladder. In females, we have two potential spaces to consider, the vesicouterine pouch between the bladder and the uterus, and the rectouterine pouch behind the uterus, also known as the pouch of Douglas. Here on this suprapubic view, we can see the bladder here, and behind is the uterus. You can see it is anteverted and anteflexed. And down here, this bright line is actually called the vaginal stripe. So we can access the potential spaces behind the uterus, the pouch of Douglas, which is the most dependent part of the entire peritoneal cavity in females. In trauma, even small volumes of blood, as little as 100 to 200 milliliters, can accumulate in these pelvic spaces. A positive pelvic FAST in an unstable patient is strongly associated with the need for operative intervention. Finally, in this subxiphoid view, we can again see the liver here, and we can actually see the heart. The slightly hyperechoic outline here is actually the pericardium. And the main thing we are evaluating here is the space between the heart and the pericardium. In penetrating trauma, detection of pericardial effusion on FAST has been shown to significantly reduce mortality by enabling early recognition of cardiac injury, even before classical signs of tamponade appear. So clinically, the FAST exam is a targeted assessment of anatomical spaces, selected because free fluid appears there early and helps to predict when life-threatening injury is present. That logic, where to look and why, comes directly from the abdominal spaces we covered. So that was everything I had for the abdominal spaces in anatomy, surgery, and radiology. I really hope you found this video helpful. I've made free courses on other topics here on YouTube if you want to keep learning. Otherwise, if you want a handmade PDF version of this lecture, take a quiz to test your knowledge, or access an organized list of all my videos, you can find everything on my website. Thanks for watching, see you in the next one.